So nutritional will be the most common ones. And what are the pointers that if you have somebody who comes to you with the rickets for the first time, has a possibility of a non-nutritional or a refractory rickets?
Having fractures associated with this like condition, or someone who has a failure to thrive, then these are the conditions.
So significant failure to thrive, features of RTA like polyuria, acidotic breathing. If you have a pathological fracture, you have to get worried about in that scenario. Now, what are the common causes of non-nutritional rickets / refractory rickets, Vibha?
Rickets. Another would be the RTA.
So renal tubular acidosis, hypophosphatemic rickets, and the most common would be renal failure. So that is something, of course, you will do it in the initial phase. So we'll try to go forward on that. So rickets seems to be a reasonably simple condition to evaluate, but often we have got confusions which go off. So we had this 3-year-old boy who was referred to us in which of quote unquote a diagnosis of refractory rickets, had been given vitamin D 60,000 international units, and complained of bone pain and a high alkaline phosphatase. And based upon these findings, the clinical team thought that this could be a possibility of a refractory rickets. But as we will discuss subsequently, that we do have some physiological responses to vitamin D, which include an increase in bone pain and an increase in alkaline phosphatase, which do not indicate a refractory rickets. And what we need to look at is the line of healing which was present in this case. So while this case was unnecessarily being advised, a lot of investigation in the form of a blood gas, calcitriol level and PTH, they were not required. So what we need to understand is that there are certain scenarios in which you will respond in a way and you don't need to work up extensively from that regard. So this is a normal response for rickets. On the contrary, we have this 14-year-old boy who presented to us with lower limb abnormalities predominantly, and had been given huge amounts of vitamin D, and there was no line of healing. He was again referred as quote unquote nutritional rickets. So in the first case, we were making physiology into pathology. Here, a pathology was turned out to be in a physiological cause, and this unfortunately resulted in the development of nephrocalcinosis. If you have a late onset rickets with predominant lower limb abnormalities with a normal PTH, normal calcium, think of hypophosphatemic rickets. So when we talk about rickets, we have to balance between the not doing too much workup where it is not required, while not missing on pathological cases. So this missing and messing is something which we want to avoid. Rickets overall is a reasonably common condition, usually nutritional, but refractory rickets may pose challenge, as we saw in the second case in that perspective. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of information about pediatric endocrinology, including resources and courses. Our e-learning portal on YouTube, which has got a lot of videos on pediatric endocrinology. Our validated courses, which provide information, including fellowship course and postgraduate courses as well. And our regular programs in the form of grand rounds, journal clubs, and PG lecture series as well. We've got publications across board from protocols to advanced in basic pediatric endocrinology and mobile applications which guide assessment. So when we talk about bone mineralization, we are talking about two important minerals, calcium and phosphorus. And these calcium and phosphorus are deposited in the form of calcium hydroxyapatite, which is a ratio of 10:6 as far as calcium and phosphorus is concerned. To avoid ectopic calcification or ectopic mineralization, so to speak, body has got specific inhibitors like pyrophosphate, which inhibit the process of this mineralization. Now, this pyrophosphate is specifically degraded via alkaline phosphatase, which is produced via the osteoblast, which degrades them, resulting in then the mineralization process. So for the bone to mineralize, you will need calcium, good amount of phosphorus, as well as a good amount of ALP. If you are able to provide enough amount of calcium and phosphorus in the body, rickets will not happen. So of all the pathophysiological causes we are talking about, be it the effect of vitamin D, be it the effect of PTH, calcitonin, or whatever, if we are able to maintain a good amount of intravenous calcium and phosphorus, the rickets will not develop. And this is something to remember from that regards. So calcium and phosphorus both are important. Which is more important probably here would be phosphorus, because phosphorus is the inhibitor of growth plate apoptosis. If you have hypophosphatemia, the epiphyseal growth plate will not apoptize. Your growth plate will become bigger, and that is what is rickets in that perspective. So the basic requirement for rickets to develop is hypophosphatemia. So while we'll classify into calciopenic and phosphopenic rickets, we need to remember that nearly all forms of rickets have low phosphorus levels. One in which you have a primary problem of phosphorus will be phosphopenic, but anybody who has a calciopenic rickets will have secondary hyperparathyroidism, and that is going to cause a hypophosphatemia anyway. So phosphorus is expected to be low in everybody who has got rickets. If your phosphorus is high, your diagnosis goes directly towards renal failure or pseudo hypoparathyroidism as a rare possibility in that regards. Now, just to go through a bit about how this calcium and phosphorus is regulated. So calcium is largely the chronic regulation is at the level of the intestinal absorption. You also have an acute change which happens from the bone, and there is a minor effect in terms of renal calcium excretions. There are three major organs: the intestine, the bone, and the kidneys, and there are three major organs which regulate. Predominantly, I will talk about two. We've discussed a lot about calcitonin in the last time as how it is a redundant hormone as far as calcium homeostasis is concerned. So most important, of course, is the parathyroid hormone, which has got multiple effects to increase the serum calcium level. It has an effect on the calcitriol production. It has the effect of getting calcium out of the bones. And via calcitriol, it also increases the absorption of calcium from that regards. Simultaneously, if you are wanting to increase calcium, you want to decrease phosphorus, because if the phosphorus goes up, you will have unnecessarily binding of phosphorus to calcium and develop hypocalcemia. So PTH is a potent phosphaturic substance in that regards. PTH also, as I discussed, increases the 1-alpha hydroxylase activity, increasing calcitriol, which is the only regulator of dietary absorption of calcium. And PTH, of course, has an effect on bone. What about phosphorus? Now, as against calcium, which is very, very tightly regulated by the body, and we want to maintain it at normal level, phosphorus is more like an orphan. There is no single hormone which is really wanting to ensure that your phosphorus goes up. You have got PTH, which is causing a loss of phosphorus. You have got the phosphatonins, which cause phosphaturia and reducing the phosphorus levels. The only hormone which can probably increase phosphorus a bit is the calcitriol by gut absorption in that perspective. The reason for this is that phosphorus is abundant in the cells. Whatever you eat, you will always get a lot of phosphorus. So dietary phosphorus deficiency is extremely uncommon. The only condition in which you can have a phosphorus deficiency is somebody is on a total parenteral nutrition for a long time, or you're losing more from the kidneys. So again, phosphorus, there are three players: the intestine, the bones, and the kidneys. But the most important player, of course, will be the kidneys from that perspective. Now, calcitriol is very, very important in terms of increasing phosphorus level. So calcitriol increases phosphorus absorption, and you will also have more phosphorus coming from the bones in that perspective. Now, what it means is that when you are treating somebody with rickets, suppose you're treating somebody who has vitamin D deficiency rickets, your phosphorus levels will be low, as we'll discuss subsequently. Once you correct their vitamin D deficiency, your phosphorus will automatically get corrected. There are two mechanisms. One, if your calcium goes up, the PTH level, the hyperparathyroidism will come down and phosphaturia will come down. The second is the direct effect of calcitriol. So when you are treating rickets, most of them will be phosphopenic, but you don't need to focus on a calcium phosphate. You can very well give calcium carbonate or calcium citrate to get a good response. You don't need to give extra phosphorus in that perspective. Now, phosphorus is being excreted in the kidneys, and a major regulator there is the parathyroid hormone, which we discussed, but this is not for conservation. PTH will remove whenever PTH is high. It will not look at what your phosphorus level is. If your phosphorus is low, it will still try to remove the phosphorus, and this becomes important in hypophosphatemic rickets. So in hypophosphatemic rickets, your phosphorus levels are low, your PTH is low, but as soon as you increase your phosphorus level, the PTH suddenly comes into the picture and it pushes off that phosphorus. So this is a very, very difficult condition to think of. Second important factor which regulates phosphorus level is the fibroblast growth factor 23, which is like a phosphatonin. So when we talk something like a phosphatonin, it has got multiple effects. The most important effect is to cause excretion of phosphorus in the urine. Along with that, it will also be inhibiting 1-alpha hydroxylase action. Anybody who has got hypophosphatemia should have a high 1-alpha hydroxylase because you want to conserve this phosphorus, and this may result in hypercalcemia. This is one condition which we see in infants who are on total parental nutrition, who are deficient in phosphorus. 1-alpha hydroxylase goes up and you will develop hypercalcemia. Now, these phosphatonins are unique in that they are not only increasing the excretion of phosphorus, they are also avoiding the unnecessary increase of calcitriol in response to this hypophosphatemia. The third major effect is at the level of PTH. They will be inhibiting PTH in that regards, and therefore, in individuals who have hypophosphatemic rickets, your FGF23 is high, you will not have hyperparathyroidism. High PTH in a child who has got refractory rickets without treatment excludes the possibility of hypophosphatemic rickets, and that's something important to understand. Now, growth hormone also plays a role in conserving phosphorus from the kidneys. That's why there is some role of giving growth hormone in individuals who have hypophosphatemic rickets with growth failure. So this will have benefits not only in terms of growth, but also in increasing their phosphorus levels as well in that perspective. Now, calcitriol and PTH both increase FGF23. And if you look at feedback, FGF23 will inhibit both calcitriol and PTH. So this is like a mechanism which we discussed already from that perspective in that regards. Now, we've talked about calcium and phosphorus, a word about a very important player in mediating both of them, which is vitamin D. So we all know that the vitamin D can be produced in the body, and it's the major source is the conversion of 7-DHC under the exposure of the UV light. Typically, in the Indian setting, we would need around 120 minutes, 10 to 3 p.m., which is something which is unusual for anybody to get. And that's why we've got so high levels of vitamin deficiency, which is the cholecalciferol. Or you can get the plant source, which has got a limited amount, a bit in mushrooms, and unless it's fortified, you won't get much from the food. This will be in the form of ergocalciferol. Now, chole and ergocalciferol are very similar in structure. They're like isomers. And there are some differences, but pretty much we can consider both as a single term as vitamin D. This is something to remember. Now, this vitamin D needs activation in the liver via the 25-hydroxylase to be converted into 25-hydroxyvitamin D, which is the most important marker of vitamin D status in our body. Now, 25-hydroxylase is a very unique enzyme in that its activity depends only on its substrate. So it's not limited. So often you will see that if your substrate becomes too much, the body decreases the enzyme so that toxicity becomes less. No, whatever vitamin D you take will be converted into 25-hydroxyvitamin D. So it has got two problems. If you give somebody very high doses of vitamin D, the risk of toxicity is there. The second is because this is independent of the substrate. This is independent of PTH. It is the best marker of vitamin D status in an individual. So if you want to assess vitamin D from an adequacy perspective, 25-OHD is the best marker. Now, this 25-hydroxyvitamin D is activated in the kidney, the proximal tubule, via 1-alpha hydroxylase into calcitriol. And this 1-alpha hydroxylase is stimulated by PTH and inhibited by the FGF23, which we discussed. Now, remember, this calcitriol then is a PTH-dependent compound. The levels of calcitriol may be low, normal, or high in vitamin D deficiency. So I often get referrals because the calcitriol is high, and somebody says, okay, this is vitamin D-dependent rickets. So you've got rickets and high calcitriol, so this means it's VDDR. No, you need to understand that this may be a normal response. So unless and until you have proven that this is refractory rickets, there is no point getting a calcitriol level done. So when we talk about our algorithm, we really put calcitriol much lower down. So don't do it in everybody in routine checkup. It's a waste of money from that perspective. Now, there is also a defense mechanism which prevents the excess of vitamin D by converting it into the inactive form 24-25 dihydroxyvitamin D. This is a bit like T4 getting converted via monodehydrogenase 1 to T3, which is active, and the inactive form via monodehydrogenase 3, which is the reverse T3. So 25-OHD is a branching player. It may be activated towards 125 or inactivated towards 24-25. Drugs that increase the activity of 24-hydroxylase like phenytoin, phenobarbital, or in the presence of obesity, you will be inactivating more vitamin D, and therefore you may develop rickets in that perspective. Now, in this perspective, if you have a deficiency of 25-hydroxylase, this will cause decreased production of 25-hydroxyvitamin D. If you have a deficiency of 1-hydroxylase, you will have a problem in calcitriol. Or if there is a problem in the vitamin D receptor, these all will cause VDDR of different forms, which Vibha will be talking more in that perspective. So this increases calcium and phosphorus absorption from the intestine, calcium absorption from the kidneys, and bone formation in that regard. But as I said, even if you have got zero vitamin D activity, you ensure that your serum calcium is normal, rickets will not develop. So the major role as far as vitamin D in the whole process is to provide calcium. Now, you may argue that it has got effect on the growth plate, it has got effect on the bone, but no, even if you have got zero vitamin D receptor activity, it's only the intravenous calcium which is good enough to ensure the overall process in that regards. Look at the possible causes of rickets. It could be a phosphopenic form in which the phosphorus is the predominant problem, or the calciopenic form in which the calcium is problem. But as I said, if your calcium is less, your PTH will go up and your phosphorus excretion will increase and you will be hypophosphatemic. So everybody who has got rickets is expected to be phosphopenic. So don't think that it's just that some forms of phosphopenic, but some, or you can say normocalcemic hypophosphatemic would be the more appropriate term. The condition which cause phosphopenic rickets could be a generalized tubular dysfunction like Fanconi syndrome, or a more specific problem like hypophosphatemic rickets. They present to us with late onset lower limb abnormalities with normal PTH, and this is a characteristic finding in that regards. Vitamin D problems could be because of a low sunlight exposure, a problem in terms of low calcium intake, and often we tend to forget that calcium is very, very important. Now, while vitamin D deficiency is common, it has been shown in that many areas like Nigeria and India, it's actually the calcium deficiency which is also an important contributing factor to deficiency and rickets. Remember that liver has got huge amount of 25-hydroxylase activity. So even advanced liver disease will only cause rickets. It is unusual to have rickets in liver disease if the patient is otherwise fine. So if you have a child who has got liver disease with rickets, think of two possibilities. One is malabsorption. Second is tyrosinemia or cystinosis, in which you have got a liver damage, which has happened in that regards. Anti-epileptic intake like phenytoin and phenobarbital will also cause inactivation of vitamin D, causing rickets. If you have problems in the 1-alpha hydroxylase effect like chronic kidney disease or VDDR, you will have that problem. Resistance of calcitriol action will again cause vitamin D dependent rickets, and these forms will present to you with early symptomatic presentation with bone pain and tetany and high parathyroid hormone levels. Now, finally, we need to understand that acidosis also has a direct adverse effects on bone health, and you can have proximal RTA or distal RTA resulting in failure to thrive, polyuria, nephrocalcinosis, and acidotic breathing. So Linda is asking, what about a patient with rickets that has been on medication for 3 months, yet to come for checkup, default treatment for 2 months, yet to come for review? How do you manage such a patient? So if somebody has a big issue in terms of compliance, that is the only other indication other than malabsorption where we consider giving an injectable vitamin D single dose or a STOS therapy, which will work in that regards. Dr. Shubha is mentioning child with rickets come to us who has taken treatment for many doctors. Should we do vitamin D level first? What level of vitamin D diagnose vitamin deficiency rickets? So if there's a long history of treatment, there is not line of healing, maybe getting a vitamin D will be of help, but usually you're already dealing with refractory rickets in that scenario. I want you to have a look at our website, at our various courses, our publications, our learning portal, as well as the mobile application.